Greetings. My name is Brad Monk. I'm a gynecologic oncologist from the University of Arizona Cancer Center, Phoenix. This is Best of the Day. Welcome to Tampa, Florida. This is the 45th annual meeting of the Society of Gynecologic Oncologists. It's my honor to bring to you Dr. Robert Coleman, Professor Robert Coleman. I call him Rob. Rob is Vice Chair at MD Anderson and in charge of their clinical research program. And it's a real honor, Rob, to talk to you about new agents in ovarian cancer.
Pleasure to be here, Brad. Thank you for inviting me.
This is great. This has been a very good scientific meeting. Clinical trials mature at different times. I think we were lucky at this meeting that there were lots of endpoints that we had to discuss. I think it's no secret that we have had 8 positive phase 3 anti-angiogenesis trials in ovarian cancer. 8. This is an established paradigm, and now it's time to sort them out. It's time to update them. And at this meeting, we talked about all of them, actually except one, and we'll review those. 4 of those 8 trials deal with bevacizumab, 2 frontline. First one, of course, is GOG 218. Tell us what's new about GOG 218.
Well, 218 was a really interesting study design. There were 3 arms in that trial that looked at the addition of bevacizumab to chemotherapy and in this maintenance setting. And I think that, as these data have matured, we've been interested to follow different aspects of the trial. And I think one of the central tenets of all of these 8 trials, since they're all based on angiogenesis, is what does angiogenesis look like in ovarian cancer? How is it manifested? And what does it do to drive that biology? And so I think what we've come to learn in recent years is that one of those features is the presence of ascites, because as we know, the types of vessels that are developed under a VEGF-rich environment are these immature, leaky vessels, poorly contacted. And so it's not uncommon to see a lot of ascites in patients with ovarian cancer. And as such, the acidic fluid is very rich, has one of the highest concentrations of VEGF. And we've known that for some time. And that kind of drove the whole reason for why this is an important compound to look at in ovarian cancer. And so one of the new aspects that we've learned in interrogating that data set is to look at how this relates to the presence of ascites.
And in fact, I think one of the biggest problems with anti-angiogenesis therapy is we don't have a good biomarker.
Correct.
And we're studying imaging and other translational research, but there may be clinical aspects, and you said it, ascites, that may predict the patient's most likely to benefit, because you said it's the phenotype. And in fact, in one of those 4 bevacizumab trials, the Aurelia trial, that actually is true, is that you can show that there's a reduction in ascites. So in 218, did the ascites patients have the most benefit?
So it was, actually, the first when I see the abstract, it was interesting to see that there was this effect that was very strong in the presence of ascites, which would fit with our understanding of this. I think, looking at all the data in totality, I also saw that there was this interesting relationship with CA-125, and I thought that was kind of an interesting piece of it as well.
What do you mean?
Meaning that CA-125, that ascites and CA-125 was actually a combined factor. They're related to each other.
Exactly.
And of course that kind of fits with our sensation about that. So, but what was really interesting was that ascites with low CA-125 was associated with a really strong negative aspect, and it's hard to understand exactly how that fits. Maybe that's a biology that's actually even worse.
But to boil it down, when I see a patient with ascites, should I say, oh, that's the patient that's going to benefit from Bev?
I think that's kind of what I think that the hypothesis that was generated.
But it wasn't showed really.
Right. So we think that from the biology, at least as this is a biomarker, I think that it fits that. We should get some response out of that type of targeted therapy within the presence of ascites. But the interaction of all of these features, like there's more disease volume, there's this potential immunological effect. I think it just raises a lot of hypotheses about how do we sort through all those things. They're competing interests, and again, it leads us back to the issue is like an established biomarker for who's going to best benefit from this is still elusive.
And benefit is in the eye of the beholder. All of these 8 trials, I say they're positive because they show an improvement in progression-free survival. Okay, and in the fall, The second frontline trial with bevacizumab, ICON-7, was updated, and it did not show a survival advantage. This is disappointing. We all want a survival advantage, but it confirmed the improvement in progression-free survival with 218.
Yes.
And then the third trial, Aurelia, was just published this week. Very interesting. We talked about that when bevacizumab is added to chemotherapy in platinum-resistant disease, that there's an improvement in the hazard ratio for progression of 0.48. And then in the platinum-sensitive space, the only one to show a survival advantage so far is ICON-7. Tell us about ICON-6. Tell us about ICON-6.
So ICON-6 was a trial that was launched some time ago as a kind of like what I think is kind of a new strategy. We call that the seamless design, where they start with a phase 1, move it into a phase 2, and then ultimately end up in a phase 3. So it was a very large program, as you know, and we had monitored this all the way through. I think we had some early hits that cediranib was an important potential compound. It has activity in both platinum sensitive and resistant. So it was important to look at that in combination, much like we did in the frontline setting and in the recurrent setting with gemcitabine and carboplatin, but to look at this in combination with paclitaxel, carboplatin, or gemcitabine and carboplatin. So,
and to be clear, there are the 8 trials, 4 with Bev,
right.
And this is the first one without Bev, but an anti-VEGF strategy, an
Correct.
Oral tyrosine kinase inhibitor, cediranib.
Correct.
Added to chemotherapy in platinum-sensitive disease.
Yeah, and it has some other off-target effects. So it has it's a multi-kinase compound. So the trial design was done very similar to 218 in that there was an arm that had only chemotherapy and placebo maintenance, an arm where it was given concomitantly, and an arm where it was given concomitantly and in maintenance. And as you know, the development plan of that drug was a little complicated, and so it became apparent that prior to completion of the full studies accrual, that they were going to take a look at the data, and so we saw was that there was this benefit in progression-free survival, as you mentioned, but also this difference in overall survival, and it was the only one of the 8 you mentioned where that was the observed effect.
And that's contrasted to the 4th bevacizumab trial. So the first 2, 218 and ICON-7,
Yep.
the Aurelia resistant, but the platinum-sensitive bevacizumab trial is called Oceans. And at this meeting, the survival was finalized, and the final answer for adding bevacizumab to carboplatin gemcitabine in platinum-sensitive disease is there's absolutely no survival difference.
Correct.
But there was when cediranib was added to carboplatin paclitaxel in the same setting.
Yes.
So is cediranib a better drug than bevacizumab? Is that why there's an OS in the cediranib trial, but not in the same space with bevacizumab? Or is it chemotherapy backbone?
So I think that it's very hard to tease them out and to do cross-trial comparisons as hazard. I'll just say that now. But but it is very interesting when you go back and you look at those trials independently. The ICON-6 trial, actually 71% of those patients were in the patient population of more than 12 months out. All platinum sensitive, right? But with a platinum-free interval of more than 12 months, 71%. In Oceans, it was just under 60. And in a non-bevacizumab or non-biologically targeted trial, the Calypso trial, it was just in between those two.
Right.
The progression-free survival for each one of those potential study arms for the control arm were exactly the same.
Exactly.
But the overall survival in Oceans and Calypso are very close to each other, but it's 6 months lower in ICON-6.
Said another way, the number of therapies after progression in the Oceans trial, I think the median was 5 or 6.
Mm-hmm. Actually, yes, the median was 5 or 6, but there were up to 14 lines.
Imagine that. So there's the front line, Oceans, and then 14 more. That's 16 regimens. It's unbelievable.
Wow.
And when you do that, the median survival in Oceans was about 33 months.
Correct.
But what was it in ICON-7?
So it was
6.
it was around the 26, 27,
Right,
27.
6 months less.
Mm-hmm.
So you're telling me, it's not exact, I'm clarifying, that because the survival was less in the cediranib study, that's maybe why there was an OS difference?
So,
Because you can't tell me cediranib is a better agent, but they lived shorter.
right. So I think that, so really these what it makes us do is it makes us look at the patient population, right?
Okay.
I mean, if the patient population is different, then the cross-trial comparisons are become very muddy. So that's why I mentioned what I mentioned.
But I got people telling me that cediranib shows OS, so it must be better. I think the other take-home message, patient populations, yes, but the real issue is post-progression survival,
Right.
and the real clinical trial endpoint is PFS.
Right, right, exactly. So, and they saw it. So this is now 8 in a row trials that are all positive for PFS, and they measures the direct effect of therapy. I think the lesson we learned from Oceans to cediranib in ICON 6 is that post-progression therapy in this particular disease is really important to an OS endpoint.
Right.
And the crossover, for an anti-angiogenesis in recurrence, almost half of the patients in Oceans ended up getting this type of therapy. And we don't know what it is necessarily at an ICON 6, but we assume it's probably at a lower rate and during the time of the trial. So it's very, very hard to do these cross-trial comparisons. It is a curious finding. But the underperformance of overall survival in the control arm, not in the experimental arm, in the control arm is very important because it's actually not just 6 months. It's more like 13, 14 months.
In the control arm.
In the control arm.
Right.
So that to me is we need to sort through exactly why that happened.
So we talked about the 8 trials, 4 with Bev, 3 with TKIs. We just talked about cediranib. We're not going to talk about ninditinib or pazopanib. But the 8th trial is a non-VEGF approach. Why in the world would you target a non-VEGF angiogenesis?
Because we're running out of things to do. No, I think that, so one of the, angiogenesis is a very complex process, right? We know it's tightly regulated by multiple pro and anti-angiogenic factors normally. So each one of those elements, including the contribution from the immune system, regulates various phases of angiogenesis, which is a process that not only is just a sprouting mechanism, but it's also a vessel co-option, a vessel mimicry. There are many of these different processes that lead to vascularization of tumors that have low vascularization. So it's that dealing with hypoxia. So one of the strongest signals from that process is VEGF, and that's why we targeted that. But there are multiple other aspects that cause the sprouting mechanism. Why do the vessels grow? What causes the endothelial cells to be unstable? So these are processes that are being driven by other factors, alone and in combination with other
angiopoietin 1, angiopoietin 1, right? Angiopoietin 1 binds to the Tie2 receptor, improves vessel quality. Angiopoietin 2 improves vessel quantity. It can be inactivated with terbinafine, formerly known as AMG 386. Okay, so that's the 8th trial, and when added to paclitaxel, it improves progression-free survival with a hazard ratio of 0.66. And the beauty of it is, I know because I'm the PI of the trial, so I can tell you, the beauty of it is that not only is there a therapeutic benefit, but the side effect profile is different. So the hypertension, proteinuria, GI perforation, wound healing, bleeding, thrombosis, and CNS dysfunction is replaced with edema. So it's great that you don't have that other stuff, but you got edema, and edema is a serious problem in ovarian cancer.
It is.
So at this meeting, that study called TRINOVA-1 was updated. Tell us about the 2 things that was updated about TRINOVA-1 at this meeting.
So as you mentioned, when you add a new compound, it's very important to understand what impact that has on people's lives. And so the quality of life assessment is really important in these phase 3 trials, as you know. And it was important enough of a side effect to actually cause you to write about it before even the trial was done, because we saw that edema was a major problem.
Because I saw it come and I treated a lot of patients.
Yeah, absolutely.
We got to understand it.
Absolutely. And I think that was a good guidance document. I think as you mentioned, lymphedema is underappreciated, it's underreported across the board. But in a trial where it's a principal side effect, it's one of these things is that can we mitigate it with early recognition? Very same thing like nausea we see with other trials and hypertension with those. So what we saw in this particular trial is that adding that other agent, which led to a PFS benefit, did not seem to negatively or positively impact the quality of life. And that's actually helpful because, as I've heard you say many times, is that it's very hard to make an asymptomatic patient more asymptomatic with a new drug that has has side effects. So I think that's reassuring, and there are competing evidence or competing effects here, because patients who are gaining benefit from therapy typically will interpret these symptoms differently than people that are not.
Right.
And
So the good news is it doesn't cause a quality of life decrement.
Right.
But the bad news is it doesn't improve quality of life.
Right.
So I understand the clinical trial ramification of that. And so let's move on and talk about some other agents. I think, and unfortunately we're not going to talk about immunotherapy. You mentioned it a little bit, that bevacizumab might actually have an immunologic effect. That's a huge topic.
Yeah, absolutely.
But let's go on and talk about probably the next most exciting, other than angiogenesis and immunotherapy, and that's PARP inhibition.
Absolutely.
So you presented at this meeting a phase 2 trial of a new PARP inhibitor. Tell us about it.
So, the compound is ABT-888 or veliparib, and it was a trial that has been under extensive investigation over the years, mostly in combination. As we learned about probably 5 or 6 years ago, that there was this synthetic lethality effect that we saw that was enhanced with the combination of specific agents that also cause DNA damage. And so this particular compound had really not seen, or there had never been a phase 2 of a single agent to see if it works in its target population. Right. So that was the point of GOG 280, which was to study veliparib in a BRCA mutation carrier population, and to see what its
How many prior regimens?
So we allowed up to 3 prior regimens, and we monitored the platinum-sensitive resistance cohorts because we knew we would get a mix of them. We also looked at the specific types of mutations, so we actually captured all of those as well. And so we looked at the founder mutations versus the ones that were not found.
But all germline mutation
All
carriers.
germline mutation
And the
carriers.
response rate?
26%, two
good.
CRs, 11 partial responses. But I think more importantly, and I think as we treat patients with PARP inhibitors, we're starting to understand, is the non-progression. So the PFS in this was over 8 months.
It's good. 8 months is good.
It is good in
And
this patient
toxicity?
population. Toxicity was actually really very in line with what we've seen before. Very little hematologic toxicity. And the nausea and vomiting is always a problem with this group of patients. We saw a few grade 3 events, but overall the grade 1, 2 toxicities, which are not trivial, right, especially with a drug that you have to take orally twice a day.
So this is the same agent that's sorted out in the I-SPY programs, presented at San Antonio Breast, that is in phase 3 trial in breast cancer, and I'm certain that there's going to be a phase 3 trial in ovarian cancer with veliparib. There are 3 phase 3 trials now: olaparib, rucaparib, and niraparib. It's a tongue twister in ovarian cancer. 3 of them. This would be the 4th. The one that we have the most experience with is olaparib, okay? And that was published in the New England Journal, and that was in the second line, third line maintenance. So patients who respond to platinum again and again, and then their tumor is essentially gone, and you give them maintenance. And in the BRCA mutation carriers, as you know, hazard ratio 0.18.
Very impressive.
I just love to remember that number. Hazard ratio of 0.18. And we're looking at more and more benefits in that study. At this meeting, there was some other surrogate endpoints, some secondary endpoints of that Jonathan Letterman, New England Journal, second-line maintenance, olaparib study. Tell us what else they told us about.
So, I think one of the benefits you would hope to see is that you could delay the next line of therapy. Right. And we know that if we're delaying progression-free survival, at least in this country, it's pretty much an automatic. But then if you have a strategy where you're waiting patients to become symptomatic, there's an additional element beyond that point where patients are starting their next line of therapy.
And that's relevant to the patient-reported outcomes that you talked
Yes.
about. I mean, the best improvement in patient-reported outcomes is delaying the next treatment off chemotherapy. Patients feel the best when they're off chemotherapy.
Exactly.
So
that's a meaningful endpoint,
right,
and it's something that's not captured well right, on trials because we're all looking about efficacy.
Some people call it PS2.
Yes, exactly. And so what they showed is that in line with the previous report and in line with the PFS benefit, that this was again extended, and it was extended not only to the start but also to the completion of the next line of therapy.
But how much extension?
It was I don't know. I have to look.
4 to 6 months.
Yeah, I mean, it was an additional, a meaningful difference. Especially since we see these patients, relatively frequently. But at least waiting through another assessment cycle, essentially.
So what's dawned on me, this concept of BRCA dysfunction, is we have clear prognostic factors in recurrent ovarian cancer. Platinum-free interval, we've always talked about it. performance status, volume of disease. These patients that have BRCA mutations live longer. That's probably the next one. In fact, in our clinical trials in recurrent ovarian cancer, we probably should measure it and stratify for it.
Great.
And so I and you, we've worked on developing a drug called trabectedin, which is a DNA damaging agent. It impairs DNA repair, and so it should work the best in BRCA mutation carriers. So I'll just tell you, since I was the presenter, that we took a randomized phase 3 trial of PLD versus PLD trabectedin, and we did a hypothesis-generating subset analysis. And in those patients that had impaired DNA repair, BRCA mutation carriers, there was an improvement in progression-free survival more than double, and there was an improvement in OS by about a third. So again, it's an unplanned hypothesis generating. But the point is, we need to study DNA damaging agents in BRCA mutation carriers, just like we need to pursue synthetic lethality. So what do you think about all that?
I'm totally on board. And I think that the first clue we got that this is really I mean, we've known that these patients are more platinum sensitive and they have a longer kind of outcome.
That's why it needs to be prognostic factor.
It is a prognostic factor. And I think when we saw in the trial that Stan K did, where they randomized patients to olaparib versus liposomal doxorubicin, that the liposomal the benefit from the 2 doses of the olaparib that were studied in that trial were where they targeted, where they thought their effect was. They hit it. What they didn't expect was that PLD would do almost double what they anticipated. So it made us think, okay, you know what? DNA damaging agents in the presence of this inability to have a competent homologous recombination is going to lead to an effect. So what your trial did was it capitalized on another nucleotide excision repair gene that you saw in your study, this XRG, or I believe that was XPG. So in a sense, PARP, which is also a single nucleotide repair mechanism, and when you inhibit it in the context of incompetent homologous combination, BRCA, you have essentially synthetic lethality. 2 sublethal events who, when you give together, show a lethal effect. And so that's basically what you guys showed, was that when you inhibit, when trabectedin inhibits, and there's preclinical data that goes back at least 6-7 years, that trabectedin inhibits XPG, just like PARP, just like olaparib or niraparib or veliparib inhibit the PARP enzyme.
It's been good to understand this biology. We sure have more work to do. So I mentioned the prognostic factors. So platinum-free interval, volume of disease, age, and now BRCA status. Let's talk about age. I get calls all the time. Very good oncologists will call me, say, Brad, I got a patient that's 80 years old, and probably somebody I operated on, and they'll say, you know, thank you very much. I'm glad that she didn't have a complication. I say, me too. and you know, how do I treat this patient in an adjuvant setting? So there was a trial here about that. What is the best treatment for that 80-year-old who has primary debulking surgery? What's the best chemotherapy for her? Because it's such an important prognostic factor, not in just the biology of her tumor, but if you treat her, she might have a serious life-ending complication. Tell us what we learned and what the best treatment is for the elderly patient.
So at this meeting, there was a report from GOG 273, which was looking at, it's kind of a sequential cohort study, not really a randomized trial, but physicians were allowed to pick 2 regimens, and now there's a 3rd arm, as you know. So one arm was basically standard therapy with bone marrow support. So it was paclitaxel carboplatin with lower doses of paclitaxel.
That's a good teaching point. The first thing, if you're going to give that patient carboplatin paclitaxel who's 80, give her growth factors.
Right. So that was
Point 1.
That was the first one. And the second arm was that you could use single agent carboplatin,
which is very acceptable, although it's not the standard because she's 80.
Right. So that was the concern. So actually the genesis goes back quite a bit, because ECOG did a study many years ago looking at the use of paclitaxel carboplatin in this elderly patient population. They found out, actually, you know what? If they're in good performance status and don't have big more comorbidities, age isn't a good factor. It's not a good discriminator. But we vote with our feet. So we have that 80-year-old patient who's in good shape, we put them on one arm. If we got that 80-year-old who's not in good shape, we put them on the single agent carbo. And that's basically what happened here. They found that when they looked at the overall picture, things like the patients who went on the combination strategy were younger, they're fitter.
And the physician's choice.
In the physician's choice, right. So we voted with our feet. So when you said an 80-year-old, to me, that's not a good discriminator. To me, an 80-year-old who's in good shape could get on combination therapy. An 80-year-old who's not in good shape, I might use this other thing. But the point of the 273 was to look at whether or not there were other things that predictors of this particular.
And they couldn't figure it out.
They couldn't figure it out. And the things that they used were actually interesting because they used these activities of daily living, and these things were like, can I get dressed? Can I brush my teeth?
Do I fall?
Right. Do I fall? And so
they were not right.
They were not different between the
two. So I think the bottom line is that remember GOG 132, that's sequential. Carboplatin followed by paclitaxel had the same survival. So sequential is a very good option in a patient that's not necessarily chronologically old, but truly old.
Right.
But in the fit patient, you can try combination, but you should use growth factors. And these questionnaires don't really tell you. You got to use your clinical acumen.
Right. And I think that with respect to both arms of the trial, benefit from therapy or treatment effect, tumor going away, resolution of symptoms, it actually, you can see that over time, that in both arms, they saw a benefit to that. Yeah.
Listen, Rob, that's a lot of stuff, and it's exciting, and it's fun, and I appreciate your knowledge and your expertise, and most importantly, your hard work. I think one of your many identities is your commitment to clinical trials and trying to push the bar, and you've been very successful, and I personally thank you. And I thank you for being with me. This is at the 45th Annual Society of Gynecologic Oncology meeting in Tampa, Florida. This has been Best of the Day. So long for now.
Thank you.